Our next presentation will be presented by Mansour AlJufan. It will be about Edwards Sapien valve for larger or native right ventricular outflow tract. Mansour, please.
Thank you. I'm sorry, I didn't know that I was next, so sorry for this. I will make it quick and so we could save time. First of all, I'm honored to talk in front of you, and I'm in debt to Professor Chelby and his colleagues to give me this chance again to come over and share some of our experiences with Edwards Sapien. So I'm just going to start with my disclosure. I'm in proctorship agreement with Edward Life Science, and you all know what kind of problems we face with pulmonary regurgitation, and I suppose this is very repetitive for knowledge that you know already. But just to give you a taste of what we have faced in our practice is in King Faisal, we have a lot of people with right ventricular outflow abnormalities. We have a lot of people with right ventricular outflow abnormalities. We have lots of homograph getting done. We have lots of repaired conotruncal abnormalities and lots of cath interventions. And we have, as everybody in the world, facing this increasing population with very sick right ventricle and failing, and could lead to end-stage heart failure and then need for transplant or more drastic intervention. If you look at actually the pulmonary valve itself in normal people, most of it lie on this range with an average body size. This is if you go to Southeast Asia, this is probably more prevalent. And if you go to the Nordic or the Mongolian race, you'll find a lot of variability in the normal annulus. And this is one of the post-mortem study to show this variability and what are the things that can control the pulmonary valve annulus. Now, what makes it actually larger than what we face or what is normal is what we do in the congenital and the structural interventions. After early repair, particularly in the neonatal time, there is a lot of regurgitation, increase in the stroke volume, and because of the tissue characteristics, there is expansibility and further dilatation of these reconstructed right ventricular outflow tract. Although there isn't much done to the annulus in pulmonary valve dilatation, but the stroke volume can lead in just pure balloon dilatation to the increment of the pulmonary valve annulus and the right ventricular outflow tract. What makes it more interesting and challenging is that the right ventricular outflow tract getting reconstructed very early, there is a lots of tissues, a lot of variability from place to place. So you find lots of material used from homographs, xenograft to polyurethane in form of Gore-Tex and so on and so forth. So you're dealing really with very different kind of subsets of lesion and patient population. Surgical techniques, needless to say, also can influence this. So in the early phase, we will save people like this who had no scars here, as you could see. They have balloon dilatation or have very dilated annulus and severely regurgitant pulmonic valve with a very sick right ventricle. And we will have no really clue what to do with them in the cath lab, so we'll send them for surgery. Now, when we are in the cath lab, we just see what we see. And what we see is the fact that these right ventricle outflow tract, they come in different shapes and forms. So you could have stenosis like this one. You could have very mobile and ill-defined lesion like this one. And one of the also challenges that we face is that not only they're expansile, but they're extremely mobile in the thorax. So trying to predict the device fit to those ones is really a challenge. We all in the very early experience with the Melody were so happy because we have a very calcified conduit and stenotic. So really not that puzzled with what could fit in these kind of lesions. But with this kind of anatomy, that was the main question, which is the stent feasibility. So we were looking at, well, if we could stent those right ventricular, if we could put, sort of speak, a transcatheter homograft that we could probably parasite on a very larger devices that are available for the left side, which is specifically the Edward, and we could put it in. And I explained to Joe when he asked me why or how did we get stumbled on this. Probably will just not repeat this. So the availability of the devices at that time was the up to 26. And then I think in late 2010, the 29 came over. And we know that the Melody is recommended for conduits or lesions that are less than 22 millimeters. So when the 29 came, we wanted to see what is available. Parallel to that, I think Early and Mario can teach all of us his initial experiment with the Medtronic reducer. And he will correct me by the end of this, or he will actually supplement what I say about it by the end of this presentation. But it was a very good experiment, and it worked. And I think there is lots of issue about going ahead and sort of like further improve the design. And there's a lot of factors that control this process, and I'm not in the situation to go through it. So when the 29 came, we looked at it, and we knew from the aortic experience that it functioned up to 30, and it can function as low as 27. And as we show in the first case that they come in, they put color-coded, and it's volume-driven. Further, when the 29 came, this E-sheet had become also available. So that pediatric or that marginal size that we deal with got a little bit palliated by the fact that now the sheet itself is lower by the sheer invention of this E design, which basically that when you put the valve mounted on the balloon in the old retroflex, when you push it out, that the sheet itself actually expands inside the body. So you don't really have to put very big poured French size. And we had shown this in our first case today with Professor Shelby, and I'm not going to go to this. So we noticed that when we actually going there and trying to see what are the sizes, and if we fail by fluoroscopy to tell or to measure, we will just put a balloon and notice that those balloons get in some marginal lesions for the 26 that they get stuck. So if they are more than 27 at that time, we will just stop and say, well, he goes for surgery. So we looked at the stent what is available for us to go ahead and stent in. And we knew that from our work with the CP stent that really it's not the best anchoring device that can actually latch on a very elusive and ill-defined structure like these structures. So we stumbled on the Andra, and I believe Peter in Germany, Peter Ebert, had experimented with it in the right ventricular after 26, and there are like 3 or 4 publications about doing Edward ahead of us to tell us, well, Andra work in the right ventricle size. And in my wet lab, when we expanded those Andra stents, we noticed that they are a hybrid cell design, so they have really not complete circles. So they will have this round notch that can give you more an anchoring sort of like security. So we looked again, we got frustrated with another patient, and we noticed this, that when you inflate a marginal size, you get this. And we say, well, if we stabilize balloon, we can probably stabilize a stent. So, and I explained to you in the first, now this is a challenge. I did not only move from PowerPoint, from Windows or PC to Apple, I moved from PowerPoint to Keypoint. So I don't know how to separate those guys, all right, but I suppose I can do this. And I just show you. I have to bring this up front, and I wasted so much time trying to do it. But anyway, so it worked. And my team and I got really burned out in the first one stent we put. We were saying, well, we'll put it for the 26, but the patients, we bring him back and he's not good for 26. So we really get burned. The surgeon says, what did you do? You just waited a stent, more morbidity and nothing done. So, so we brought some of these patients back and we discovered they are not actually good for 26 because they are more. And we will test them. And we will look again with that initial stent placed for a tug or for stability of stent. So we said, okay, we are going to do the 29. And I described to you in the first case how did we actually do our patient in late 2012. These are the marginal, and we showed you this, so I don't have to repeat it. And off we go. I think this is our first 29 we did. And it worked. And it worked despite the fact that we reversely mounted it. So at the present, we have done more than 14. 3 of those 29 are hybrid in a hybrid lab. And we send our patient when they are really beyond the 30 range. So if we cannot stabilize a balloon that is 30, then we send those patients for a reduction surgically through a mini sternotomy. And then we go in the initial stage in a transventriculary, but lately we have been going through the femoral with the reduction. So this is a hybrid that we come from the ventricle, and as I said lately, we would just have the surgeon put the plication on the very, very, very large right ventricular flow tract with secured interrupted sutures that are separated from each other. And he will still put his finger just as a safety when we put these very big system or under stent 10. Now, I want to make a distinction. There is, it's 2 different words, is the native RVOT. When we want to stick to definitions, when we say native right ventricular flow tract, it means that there is nothing other than the patient tissue. So no tissue whatsoever, either from homograft or xenograft or Gore-Tex. And we have done actually some of the pure native diseased right ventricular outflow tract, and we have been so far blessed to have really good results with them. Now, what is new on that regard, of course, that this device is, when it came initially, it is not meant for pulmonic. It is just us that are confronted with these difficult cases that we tried to make use of these systems, and it worked for us. But I think together we and the industry and their RD are supposed to really work very closely to make the system more fair. For example, we don't need this rotational thing on the NovaFlex at all. And as Joe pointed out, or wanted to point out, that the reverse mounting is still really a questionable thing on the longevity and the integrity of the device itself. So I think we still have, the best that we could say that this is successful sort of like an effort, and we hoped had done it in a very careful way. In the pipeline, and it's not really certified or CE marked for pulmonic, a new certitude introducer that doesn't have the rotational. So the advantage of this that you go low, very low with the introduced sheet, and they did little bit of changes. It's not colors now, it's a number that they write on it, and it becomes really as low as 18 for a 29 valve, which is really a plus from 20. And this is the new Sapien 3 that is meant for the aortic valve, and it's again not CE marked for pulmonic. So between the balloon expandable and the self-expanding, and also there are some venous valves, I think Shaq or somebody else is going to talk about them during this meeting. We will continue to try, but I have to say that we are not yet there to be as good as what is available for the aortic valve. And I just want to throw a thought by the end here before I conclude, is that, as good as it gets that we try to make something mimicking nature, there's nothing like a biological valve. The left side picture you see is actually a Contegra or a Melody valve that is pictured with a camera inside a beating heart that is made beat by in a special lab. It's a project called Visible Lab out of Minnesota. You see the movement, they're not really as jerky and as pressure dependent as what we try to make by making those bioprosthetic, such as the valve that we spend work on. So as good as it may look, I think biological valve in the long term are going to be the valves that I suppose generations will come and they will make this migration too. So I would conclude by saying that the native or patched RVOT exists in large population. We need to address it, and in the current patient mix we do, and we have to have full knowledge of the tissue composition, either genetically determined, patient tissue differ from a patient to a patient, the expandability, what have you, the type of collagen and what have you, and also what we do surgically introducing other tissue. And I'm saying it because it really depends on, it will influence the way that we put these pre-stenting, or if we think about designing valve, we really have to account for this. It is, I have to say, that this anatomy is not largely for the commonly used or the easily used now percutaneous pulmonary valve implantation. Not only the device or the valve, but even the tool. So the design has taken account the certain variables, one of which is to preserve the function of this bioprosthetic. There's a lot of, in the TAVI, and our TAVI group, they will tell you that the valve will function, or by design, when it's completely circle or near circle. However, there are studies to show that most of these valves are not circle when they're implanted in the left side, and they're still competent. So this kind of thoughts that are thrown around the lesion should really dictate upon us to think deeply and thoroughly on what are the next step on that. And I conclude. Thank you very much.